Welcome to Talking Science Africa, a show where we bring you researchers and scientists in the science space to talk about the work that they are doing. Today, we bring you Dr. Moses Ntaro, who is graduating with a PhD in public health from Makerere University 76 graduation ceremony happening this week in February 2026 at Makerere University. In the second decade of the 21st century, when most of the researchers are thinking about AI, digital health, medicines, and data science, Dr. Moses Ntaro's PhD thesis focused on something simple, but which is very, very important for our which is very important for our everyday life. That's where we relieve ourselves from every day. Doctor, welcome to the show.
Yeah, thank you very much, Mr. Mbizi.
And congratulations on earning a PhD.
Yeah, thank you. Yeah, thank you.
It's a difficult journey. It requires a lot of dedication, it requires a lot of time, and I think it's not an easy job.
Sure, true.
Yeah. So the first thing is that this question, every day, every person has to go and relieve himself or herself. Yet it's something that, we do it every day, but then you don't find it every day in research papers. In 2026, where we are, what's the current state of open defecation in Uganda?
Yeah, thank you, moderator. And like you've mentioned that, especially the time people think about AI, people think about other technological, other conditions and diseases. Why this issue where people go and relieve themselves? One of the things I'll start from is that, when we talk about, because as science I'll use the right words, so we talk about relief, but we need to talk about feces. Just a small gram, very tiny, carries millions of pathogens, disease-causing organisms, which when they get to the environment and where there is pollution, will remain with diarrhea. But coming to your question directly, is we are around 20%, because 20% of Ugandans up to today do not have toilets, latrines. So a number of literature has given it between 23 to 24. That's where we are at, as far as people don't have toilets and can ease themselves in the open, which we call open defecation.
That seems like a big figure for me. 2 out of 10 people having no toilets in Uganda. Why? What causes this stuff?
I think we know that sometimes there have been improvements and the efforts by the different stakeholders, of course the government leading, to see that every household is able to have a toilet. But we have had a number of factors. I will sometimes use regionally. Some people who build latrines, these latrines sometimes they are weak in terms, when I say weak, they have used ordinary materials during, weather harsh conditions, rainy seasons, they collapse. And definitely this takes them back. We call it slippage. They backslide and go back to the original practice. So those are some of the factors that have, especially temporarily, not having strong. But the other key aspect is that the communities in some aspects, some areas, may have not yet perceived it as a very dangerous practice that needs to be addressed. So maybe I can focus on those two for now.
When you talk about 20%, it may still be an abstract figure for me. If a person says pinpoint places or regions, which are those regions where this practice of open defecation is still common?
So when you look at a number of our documents, country documents and reports, Ministry of Health reports, they try to show you that this practice must happen in rural areas. However, not saying that's not in the urban areas, but in rural areas. But also there are also other areas which we have known traditionally, that open defecation has always been high. Like when you talk about the Karamoja region, in some places it has always been high. But however, that does not rule out the other rural areas where it's not high, but like I mentioned, however small open defecation rate is happening, it is dangerous to the community. And we shall later go into details that the step number 2, not only looking at open defecation, the one you see defecate in the open, but we have gone further. The scientists in the area have gone further to say we are not going to talk about open defecation, but talking about open defecation-free environment, where it goes beyond only having feces in the open, but all the transmission routes, meaning the transmission routes, all ways where feces can go to the oral. Remember when we are much younger in primary, we hear about the F5s. So all those routes are cut off. So there is hand washing, there is a toilets available, there are trees always covered. So we go into further detail to explain what open defecation free is.
Over the years, what interventions has government put in place and this problem, and to what extent have they worked or not worked?
So we, as government, especially in the area of sanitation promotion, there have been a number of interventions. Of course, for me, I'm in academia, but those that have also, found out as I looked at literature, there have always been, things like health education, where communities would be educated, how, do hand washing. There have been hand washing campaigns, even if you heard about hand washing campaign, days trying to promote hand washing as a way to cut off the feces which can come out from the hands to the mouth. There have also been what they call home improvement campaigns, where homes compete with one another to see about cleanliness. But most recently, and which the strategy which the country has been using currently, which is called community-led total sanitation. Community-led total sanitation. This is where the community are made aware, they are triggered to understand that actually open defecation in an area, in a community, is dangerous. Eating people's feces, because what they mean is that where there are any feces in a community, it is very simple for them to move by flies, get to our food, move by water, get to our water. So when these techniques demonstrate to the community that actually that is happening, and then the community say, how can we be eating each other's feces? They come up with a collective action, say, this must stop. That's what they call community-led total sanitation. And this current strategy has been used, which is being used in rural areas. The other strategy, which is sanitation marketing, I think it's an upcapping approach, so that products, sanitation products, are made commercial. They are commercialized. Those are some of the approaches that I can quickly pinpoint to.
You mentioned about areas like Karamoja, which had this problem for a long time.
Yes.
Are there specific interventions that government put in areas like Karamoja, and did those interventions work?
I think this generally the CLTS approach, when it came up, it first targeted areas that had very, which were most poor as far as open defecation baseline is concerned. So I agree with you that this strategy, when you look at some of the literature which is available, has worked in some of these areas that had high, we can call the high baseline of open defecation previously. And they have helped, actually, CLTS, some of the areas really where it is employed and it's followed up. Communities end up really dealing away with open defecation, and they become what is called open defecation free communities.
So, focusing or selecting an area for a PhD study, I assume is not an easy decision to make. So you tend to have a lot of subjects, you think about this, you think about the other, and then you weigh them, you talk to your researchers, and etc. before you come to really the area that you want to spend your PhD energy on, and which also must be an area that you love. How did you end up focusing your PhD thesis on open defecation?
Yeah, that's a very interesting question, and it's really a thought process by the time you focus and focus to your research, and sometimes we call the research gap. So one of the things that triggered me is I have been in my responsibility as a lecturer in community health, and previously also coordinating a community program that we call community-based education program, where we have our students, health professional students. They are grouped in groups of 5 and sent to a rural facility where they work with the communities to identify a health challenge, and then work together with the community to come up with solutions, low-cost solutions. So one of my sites had been in Kabale, Rubaya, and year after year I would go with my students and we do what we call a transect walk. A transect walk is walking through the community to identify what issues, what health challenges are in this community, what resources are available. Glaringly, we were always met with this, with this glaring open defecation in the areas where we do transit walk. And so, as one of the requirements of students were to review records at health centers and see what are the most causes of illnesses. Interestingly, among the first 5, intestinal worms, diarrhea diseases would always be surfacing. So, as a scientist, you'd link the two quickly. You'd see, high level of open defecation. We're also seeing it, in the health facilities as far as the disease burden. And fortunately, I had started already understanding some of these approaches and had a chance to interact with Kumar Carr and Robert Chambers, who are the initiators of CLTS, in a conference. So also knowing that this is a strategy which has already been taken up by the country, it was easy to say, can students use this intervention to reduce this open defecation in the community? So that's how the idea was birthed and later grew. I conceptualized it into an academic work.
Which year was that when you started saying this open defecation in Kabale, walking around community?
So honestly, I can talk about over 7 years ago. Over 7 years ago. I think even 8 years ago when that site began. Some of the sites that we are running, we have over 60 rural sites. When I talk about 60 rural sites as a department, as a faculty of medicine in Mbarara, is that these sites are normally, they are housed by health facilities, which are either health center, 3 or 4, or sometimes a district hospital. And so they host the students, but the students work with the communities that are served with that facility. So that is over 7 years ago. Yeah.
I had thought that this was like in the early 2000s or the late 1990s. How come that we still had, I would say perhaps high, I don't know if I'm right to say high rates of open defecation in the Kabale 7-8 years ago? What are the social factors that influences open defecation in the community?
Yeah, I think that's a very important question to ask ourselves around this time. As a researcher who participated, who grounded himself in this work, there are some aspects which we identified from the study. One, of course, talking about the other factors I had already hit on, which I may not go back, seasonal issues which make people lose their toilets, and so you know the terrain. So some people really, when it rains, a number of toilets are lost. Some of these areas.
The rain sweeps away.
Yes, they are swept away because sometimes they are temporary. Even those which are a bit semi-permanent, they are washed away. But in addition, there were also other social which I can say soft aspects, which were not seen as perceived as important by the communities. For example, to see that people often do, you must, because I want to bring it in a broader perspective, because before I narrow it down, because for you only look at the open defecation as the feces that we see. But also we are saying open defecation free. I don't want us to lose that discussion. And the reason why, and moderator, you must understand this, why we talk about open defecation free is evidence of reducing diarrheal diseases only happens, not that because we can't see any feces around, but if people are not hand washing appropriately after visiting the toilets, if flies are still hovering, the latrines are not covered, still diarrheal diseases can never leave the community. So we emphasize that don't only say we can't see any more feces in the vicinity, but also we look at all those other transmissions which are likely to bring these feces, which either on food or on somebody's mouth. So you would, when in our discussion with the community, they would perceive hand washing regularly after visiting a toilet was something that you are showing you are proud. How can you continue to wash hands every time you visit? It was not seen as something that you are practicing, good health behavior. Maybe the important one would have been before you go to eat, but every time you visit the toilet, it was not perceived as something that is important to the community. So those are some of the soft aspects which we saw that kept communities not to be open defecation free. Yes. So, and the other one, before I forget, there are some practices, and you need to appreciate them. Now, in Kabale, people go to dig far where the gardens are. They ask me a question: do you expect us to have toilets in every garden? As
in the mountain.
In the mountain. Is that what you expect? So, and of course, as a scientist, they had reason. Those were valid reasons. When they go to graze, when they go to cut, cutting, they call it, cutting fire, whatever it is. They don't move around with toilets. So those practices have also still kept open defecation to be high at this time.
You are right. In fact, when I'm moving in my village in the community, in the hills, there are kids who go to rear goats, there are kids who go to graze cows, there are those who go to firewood. There are lots of things that they will be doing in the hills. And there are no toilets in the hills. And it's obvious that you are going to find.
So if you do transact work in that, you will have to find open, which is dangerous, because we said that we don't want flies to pick feces anywhere and carry them, and so we must work. And I know you later, I don't know if you later ask me a question of some proposed solutions, but maybe I'll come to that when we get to that question.
So this is a PhD thesis.
Yes.
We know that PhD thesis tends to give some recommendations here and there.
Yes.
Given the magnitude of this challenge that we still have, what are the recommendations that your PhD thesis gives in dealing with this challenge?
So one of the there are a number, but I think I will focus on some which are of high impact, and also looking at the work that I focused on. There's an aspect I left out, but it's good I also bring it out at this. Another driver of open defecation is also alcoholism. In areas where there was a bit of high level of alcoholism, it was also a bit, and when interviewing such people whom I can say were in that category, who managed to participate in some of our discussions, they would say, if I come and the toilet is closed, you what? How do you expect me to help myself? So they have also been a bit perpetrating the behavior. So let me come to the solutions. So CLTS, which is community total sanitation that I talked about earlier, has worked in places where there is the baseline open defecation being high. But the challenge that is there has been scaling. How do they scale it up to all rural areas? So one of the questions that was embedded in my PhD, can we have other players who can also contribute to the scaling up of CLTS, this community total sanitation? And I said, but we are promoting community-based education. Community-based education means that most of the institutions will have their students rotate in a community as part of their classroom. So I said, with this massive, which is going to grow, if we are able to recruit them, train them, prepare them, and they use the techniques available, can they also add, they are not replacing, but add as players. So that's why I recruited those health professional students who were oriented by the district through CLTS. And these areas where we found this level, after doing a baseline of CLT, after doing a baseline open defecation, they participated, triggered these communities, and actually there was evidence that in the areas where they worked, open defecation reduced more than where the traditional health workers were working. Not that traditional health workers were not working, but they are few. They also bogged down with other responsibilities. So where these students went, they became a massive force that was able to trigger and communities. By the way, there is another thing embedded in CLTS, community total sanitation. People are not ashamed. There is during CLT, there is what we call the walk of shame. We walk around the village under CLTS to identify if there is any feces anywhere. So if somebody who is used to the community walks with the community members, there's nothing new. Yeah. But then the community is a bit ashamed when they see a visitor comes, hey, we have identified this and we are going to do an experiment, because the CLT experiment is done in the open. And people say, we have been eating feces of each other. So also students being new faces also trigger change in the community. So that is one of the recommendations that I have, that if we are able, if the government is able to not only see these community-based education programs as just learning platforms, but can we embed them into our programming, as also human resource to support the delivery of such an intervention? I think it would be a good thing. And the last and least on that, which was also homes where you found men being involved in sanitation, participating, where you found men able to answer questions about sanitation, understanding them. Surprising, those homes were most likely to be open defecation free compared to the ones where men were not concerned, saying sanitation issues are for women. So I think also involvement of men is critical as players if we are able to roll out and improve the sanitation of our communities.
So men, wherever they are, they should be involved in improving.
Yes, they are men involvement. Yes, men involvement, because sometimes they say, the sanitation issues, open defecation issues, children where they have spilled, women should go and clean those places. So you find that there is those homes remain lagging behind.
Yeah. So if you are proposing this massive, large scale of using, of sending students to the community to work with health workers, how long should they be there?
So it needs to be done in an organized way. If students are able, for example, Makerere University want them to be spending at least 2 months, which we think 2 months, it may look to be small, that in a year only 2 months, how will they sustain? But whatever they do, in those 2 months. Now the health workers also continue adding on, and when they come back another year, they also add on in terms of following up, so that it becomes a long-term project which is able to be sustained. Yeah, because it's important, yeah, that they spend longer, because the argument is that they are spending less time. How are we going to maintain these benefits? But they are also full-time workers.
Yeah, I may not have the number of students in medical school, nursing schools.
Yes.
Who I presume are the ones that should be sent community.
Yes.
It may be 10,000, it may be 20,000. We may not have that right figure. But is this number enough for a count of 50 million people?
Yeah, good one. One is that I think we should begin where let us start. That's number one. For example, if I talk about Must where I am, we have a population of almost 500 students annually, whom we are scattering across 17 districts. So imagine these 17 districts where they have scattered. They may be small portions, but if they are being done year after year, we shall realize an impact maybe in time of 5 years. Because I've even realized, before even we talk about just the CLT approach, is that wherever students go, the little projects that they're able to do, those communities sometimes don't remain the same. So if it is an organized way, and look at, I've talked about Mbara, we have now Makerere University, we have Soroti University, we have Guru University, we have Lira University, we have Stema University. The universities are growing. We have Kampala International. The universities are growing and they will continue to grow. If they become agents, and that's what universities actually are supposed to be, social accountability, they should be agents of change wherever they are. And what resources do we have? It's the students and their professors.
The SDGs target that we must end open defecation by 2030.
Yes.
Given
4 years from
4 years from now.
4 years
Given that we still see that 2 in 10 people may not have latrine and other factors. We have talked about the period open defecation. You are in a garden far away from a toilet, you will not run, you will not walk 2 kilometers back home to look for a toilet. Given those factors, are we going to end open defecation by 2030 as a country?
When you mentioned that, you triggered me to remember that globally, it is still 555 million people are still practicing open defecation. I had tried to calculate that to see the kilograms of feces, and I was seeing it was about 111 million kilograms. Imagine that.
111 million
kilograms in the open. So it is a scary situation. But I mean, because when it is scattered,
people say it is manure.
When it is scattered all over, maybe you can say there is a dilution. However, it's still a big challenge. So coming to your question, in 4 years, are we going to meet the target? I think the answer, there has been progress. We may not meet the target, but trying to look for these innovative ways so that although we don't meet the target in the 4 years, some of these innovative lessons become lessons for us as we move into the next goals which will be set. I think we can still be able to make progress. But your question of meeting the target by next 4 years, I don't see it happening. And not only for Uganda, actually, for
the entire world.
And the worst is Sub-Saharan Africa.
I thought the worst was India.
Indians, but they are improving, because the recent literature shows there have been some improvement. Of course, India, the Asians have had a bigger problem. Thank you for bringing it up. Have had a bigger problem, but in the improvements, Sub-Saharan Africa, we have remained stagnant.
You are still lagging behind.
We are still lagging behind. So if we are not careful, you may find the Asians coming down, and then we will still remain stagnant.
Which means that we need think board and act board if we attain open defecation
Yes.
in Uganda, in sub-Saharan Africa, not in the next 4 years,
Yes.
but it could be perhaps 10 or 15 years.
Yes.
Say that by 2040, Uganda has that dream of being a higher middle income country. So we should not reach that higher middle income status when we are still having open defecation as a country.
Okay, I think it's a good target. it's a good target. But I will still emphasize, as we are coming close at the end, is that we are not only looking at open defecation, but we are looking at creating open defecation-free environment, which goes beyond just having feces in the open, but all the other sanitation, hand-washing behavior is happening. The latrines are in place, they are constructed. Fly-proof controls, toilets are controlling flies, they're not hovering all around. So all those things, it should be a package that has to be looked at if we are to reduce the burden of diarrheal diseases in our communities.
Thank you. It has been a big pleasure talking to you. And once again, congratulations on earning your PhD.
Thank you.